Let's go on. So we are now talking about cell injury. Remember what we said: when you apply a stress to a cell, it can either undergo adaptation, some changes can happen, and later on the cell survive. Cell adaptation is reversible, but cell injury is where you have applied a stressor to a cell, but then the stressor is too much, the cell can't adapt, so it becomes irreversible. So it can undergo cell injury. Now, let me not say it becomes irreversible, because sometimes the cell can fail to adapt to changes in the environment, so it will undergo cell injury. The injury itself can either be reversed or it can't be reversed. All right. So injury may progress through reversible stage and culminate into cell death. So if the cell injury is irreversible, it leads to cell death. What happens is this: when you apply a stress to the cell, it can't adapt, it is going to be injured. And when the cell is injured, there's going to be functional changes. Then the way normally supposed to function, there will be some changes in function. And those changes in function, later on, you are now going to see morphological changes. Morphological changes, now you start seeing the actual change in the shape, in the size, in the appearance of the cell. So what it starts is that the cell has first lost the function, and then later on, the cell's shape starts to change. So any cell injury results when there are stressors which are so severe that the cells are no longer able to adapt, or maybe the cell is exposed to inherently damaging agents, or maybe the cell suffers from intrinsic abnormalities. For example, if there's a problem in DNA or proteins, the cell will just communicate to itself that, okay, bro, I think we are making what is not right. Let's kill ourselves. So that is what happens. Normal cell there, if there is a stress, it can go into adaptation. If the cell fails to adapt, it can be injured. Or if there is an injurious stimulus, the cell will undergo injury. If the injury is not too much, it can be reversible injury and then the cell will become normal again. But if it is severe, it will become irreversible injury and then the cell undergo cell death. And cell death can either be necrosis or apoptosis. What causes cell injury? For number one, if you don't give the cell oxygen, you deprive the cell of oxygen, and that's known as hypoxia, hypoxic cell injury. So hypoxic means low oxygen being delivered to the tissue, and you people have talked about the biochemistry of cellular respiration. We did talk about glycolysis. We did talk about the uric acid cycle or the Krebs cycle or the tricarboxylic acid cycle, and then that will go into oxidative phosphorylation. For oxidative phosphorylation to happen, you need oxygen, because when electrons are being transferred in the electron transport chain, they're being transferred at the end of it, or they're going to be given, right? The hydrogen will start entering into the inside of the mitochondria, and they to react with oxygen to form the water, and then ATP is produced. So if you don't have oxygen, it means that you can't form ATP in the electron transport chain. And ATP is necessary in that it is going to provide energy for ion pumps to work. For example, ion pumps, you need ion pumps for different ions to flow inside the cell and ions to flow outside the cell. If you don't have ATP, what will happen is that calcium will start going into the cell. When calcium is going into the cell, it has got bad effects, deteriorating effects. And then ATP is also necessary in that it is going to help in maintaining these glycogen stores. So if you don't have ATP, because you have the glycogen stores are also ATP dependent stores, what will happen is that the glycogen is going to be depleted, because glycogen is going to be broken down, and then lactic acid is going to accumulate as you are getting to break down these different products in the body, and that will lead to acidosis. Acidosis isn't a good thing. You understand later on. We have got a topic in chemical pathology. And ATP is necessary also for protein synthesis. So if ATP is low, there's going to be reduction in protein synthesis. So you can see also all these happens just because you don't have oxygen. So that is very bad. So the other reasons that can cause cell injury is physical agents like just a mechanical trauma, maybe deep cold, sudden changes in atmospheric pressure, electrical shock, chemical agents also like drugs, things like alcohols, drugs, and also immunogenic agents. Okay, thyroid, for example, thyroid damage, it can be caused by an auto antibodies. These are immunogenic, they are part of the immune system, so they can injure the cell. And then genetic disarrangements. For example, if someone has got sickle cell anemia, the genetics are not proper there. So all those can cause problem. Infectious agents also, nutritional imbalances, all this can cause cell injury. So when cell injury happens, you are going to have gross changes to the cell, things that changes that you can see with your naked eyes, and then you're also going to have ultrastructure changes, things that you can't see with your naked eyes. You need a microscope. So these, for example, it will include the cell can swell, okay, the mitochondria also can swell, the endoplasmic reticulum can also be dilated, the lysosomes can end up uh, being ingested. That's known as autophagocytosis. Lysosomes are phagocytosed. Okay, actually, not lysosomes being phagocytosed, but when the lysosomes realize that the cells are failing, they'll start getting those organelles. They start chewing them. So lysosomes are eating their own organelles. So these are some changes that can happen. So starting with reversible cell injury, this is when injury has happened to the cell, the early stages of injury, you are going to see some morphological changes and ultrastructural changes. Remember, this is reversible. You can reverse it, right? So when you look at the microscope for a cell that has undergone reversible cell injury, you see that the cell is going to swell. There is also going to be fatty change. We'll describe more about the fatty change, but then you are going to see there's going to be a difference in composition of the adipocytes. So those are the things you'll be able to see with a microscope using a light microscope. And then ultra structural changes, these are very small changes happening to the actual organelles. At least this is a cell, you can see a cell on a microscope, but what is happening to the organelles themselves is also a bit of hard for you to see. These are ultra structural changes. For example, the cell membrane can be altered, the mitochondria can also swell, and you'll be able to see small depots in the mitochondria. The rough endoplasmic reticulum and the ribosomes attached to them can also swell. Okay, that is important. For irreversible cell injury, please take note of this. This is important. When you continue to apply this stressor to a cell, what is going to happen is that the stressor, sometimes the cell can't recover. So the cell will end up now dying. That is irreversible cell injury. What you see on light microscope for irreversible cell injury is that the cells are going to lose RNA. RNA is basophilic. This is the first topic that we did in human anatomy and histology. RNA stains blue. And so because of that, the cells are going to stain the opposite because we have lost the RNA. They will start staining eosinophilic pink. The cytoplasm is also going to be forming more like vacuoles. And then the chromatin, nuclear chromatin, will be clamping together. Those are changes that are going to be happening in light microscope. Ultrastructural changes that we are going to be able to see is that the membrane is going to be able to break, cell membrane. And then we are going to be able to start seeing large densities of mitochondria. And then there will also be changes that will be happening to the nucleus. And the thing is, you need to know the order of these changes, right? You can see I've even put it here. So the first change that will happen to the nucleus is known as pycnosis or pycnosis. This is where the nucleus tends to shrink. The nucleus becomes smaller. And so because the nucleus contains RNA, which is and the DNA, which is basophilic, there's going to be increased basophilia. Okay, so what is pycnosis? Is increased the basophilia. Is basically the cell, the nucleus being able to shrink, becoming smaller, or being condensed. The nucleus is being condensed. The second change in the nucleus that happens is karyolexis. Karyolexis is now where the nucleus that has been condensed, it will now start breaking into fragments. That's karyolexis. And then the last one will be karyolysis. That's breaking. So there's going to be now the fading of the chromatin. The nucleus is now dissolved. So you can see the cells, they don't have any nuclear material in them. Please take note of the order, right? Pycnosis, karyolexis, karyolysis. So this is something that we can read here just to compare the reversible and irreversible cell injury. In reversible cell injury, the cell can recover itself, and it's the earliest change associated here will be the cell can swell, cytoplasm you can form vacuoles, okay, and then the mitochondria can swell. There's going to be fatty change, plasma membrane bleed. Blebbing is where, the way, which cells can I mention? The way dendritic cells are, the way they are. They have got those things that come out, but not really the way dendritic cells look. Think of any phagocytic cell where you have got not a normal round shape of a cell, but you have got more like hands going out, coming, going out, a lot of hands going out like that. That's blebbing, right? And then there can also be damage to the endoplasmic reticulum, and that can lead to a loss of protein synthesis because the ERA, specifically the rough ERA, is where ribosomes are found, where proteins are made. There's also going to be eosinophilia due to decreased cytoplasmic RNA. RNA is going to decrease, that's why the eosinophilia. So within the limits of the cell can compensate for these uh, problems that have happened. The cell can compensate when the stimulus has been removed. But irreversible cell injury is where you have got excess injury, and so the cell is going to end up dying. There's going to be severe mitochondrial damage with appearance of large amorphous density in mitochondria. There's going to be extensive damage to the cell membrane, increased eosinophilia, numerous myelin figures, swelling and rupture of lysosomes, and these will start now chewing their own cells. And then the nuclear changes that will happen will be pycnosis, karyolexis, and karyolysis. This is not the right order here. So that is what happens. So how does cell injury happen? Specifically, the mechanism of ischemic cell injury. This is ischemic, right? Ischemia. Ischemia is where a cell is dying. You are not supplying enough oxygen to it. So what is going to happen is that you don't have enough oxygen. The reduced oxygen, what will happen is that there's going to be decreased oxidative phosphorylation, there's decrease in ATP production, and that it would decrease membrane integrity. So the cell membrane, because there's no ATP to maintain its integrity, the ions will start flowing in and out, and so there is loss of ion gradient. And calcium will start to enter the cell, and when calcium enters the cell, that is what leads to problems. Another mechanism by which cell injury can happen is that there is decreased the phosphorylation. Phosphorylation, let's say oxidative phosphorylation has been decreased. So what happens? You don't have enough oxygen. Why? Because of hypoxia. And so oxidative phosphorylation is decreased. So the cell will take up anaerobic metabolism where you're not using oxygen. But that procedure produces lactic acid. And lactic acid will still cause the calcium influx, and that can as well result into the same problems. Okay. And another way in which cell injury happens is the accumulation of oxygen derived free radicals. We call these free radicals also as reactive oxygen species. Things like superoxide, hydrogen peroxide, these things are bad. Okay, what do? Free radicals actually are formed when there is an unstable atom. Normally, an oxygen atom is supposed to have two electrons, isn't it? In the two electrons in the outer orbital. But for reactive oxygen species, they only have one electron in that outer orbital. So it is not stable. So this atom is always trying to maintain stability by entering into another reaction so that it can gain or maybe release that electron. And as that is happening, so just a moment. Okay, sorry for that. Sorry for that. Don't know what happened. The network just went off. Did you get up to hear the screen that is showing? Did we get what is showing on the board? Okay. So as we are saying that the reactive oxygen species are going to be, these guys are unstable. So what happens that the reactive oxygen species wants to step into another reaction so that they can attain stability. And as they step into another reaction, those same reaction in which they are stepping are the reactions that can lead to cell death. Okay, because as the reactive oxygen species enter these different reactions, what they do is that they are going to activate enzymes inside the cell. Enzymes will cause autolysis. That is the breaking of their own cells. So free radicals, they will do is that they are going to damage lipids, they will damage proteins, they will damage also nucleic acids. So that is what happens. Okay. So the many damaging effect when you have got the free radicals will be they are going to cause lipid peroxidation of the membrane. And when there's lipid peroxidation, what that does is that it leads to damage of the membrane organelles. And if there is a damage to the membrane organelles, these membrane organelles, and that's what we are calling a cell death. Besides that, these reactive oxygen species are going to cause oxidative modification of proteins, and when they modify these proteins, they are going to lead to protein fragmentation. That's destroying proteins. Again, these reactive oxygen species can damage DNA, and that can lead to cell aging and malignant transformation of cells. If there's a damage to DNA, that causes the problems, actually the worst problems, because DNA, is very delicate. This is what leads to mutations that can cause cancers, malignant transformations. Okay. So when the body produces free oxygen radicals or reactive oxygen species or free radicals, how does the body cater for those so that they don't destroy us? Because we can't stay away from them. So we have got in the body what we call free radical scavenging system. So we have got certain substances in the cells that do remove these free radicals, and so they will minimize the effect that the free radicals have on our bodies. For example, we have got antioxidants like vitamin E, vitamin A, vitamin C. Okay. And then we also have enzymes. Enzymes like, for example, enzymes should be able to break down hydrogen peroxide. Hydrogen peroxide, is one type of the reactive oxygen species. And you also have superoxide anions. For example, catalase. Catalase is the one which will break down hydrogen peroxide. You are going to see that also some bacteria, they have got the enzyme catalase. What happens is that when catalase is produced, when bacteria enters our body, the body can also form these reactive oxygen species so that it can destroy the bacteria. But the bacteria was also intelligent. Some of them, they have got the catalyst. They to be breaking down the reactive oxygen species in such a way that when it breaks down the reactive oxygen species, you will not be able to destroy the bacteria. And that's how some bacteria hide from us and they end up destroying us. You also have glutathione. Glutathione is also going to break down hydrogen peroxide. We talked about this in biochemistry also last year, so we know already the mechanism. When it breaks it down, it will form water, which is which is not harmful at all. So if there's a balance between the free radical generating and the free radical scavenging system, then there's going to be oxidative stress that can cause injury, because the guys that destroying the free radicals and the free radicals themselves, they should be balanced so that what is produced can be catered for. Okay, so what happens is that with this irreversible cell injury, when it is still there is going to be cell death, and cell death can be necrosis or apoptosis. So what happens is this: when you apply a stressor to the cell, the first thing that happens is reversible cell injury. In reversible cell injury, what is happening is the function of the cell is decreasing. It is deteriorating. The cell can't perform the function that it is supposed to perform. And then after some time, if the stressor is not removed, what is going to happen is that the cell is now going to undergo irreversible cell injury. In irreversible cell injury, the first thing that will happen is the death of the cell death. After the cell dies, the first thing that you're going to see is there will be ultrastructural changes. The changes, for example, to the ribosomes, the changes to the mitochondria, and then there will be changes that you are able to tell on the light microscope, changes to the actual cells themselves. And that's where now you're going to be able to have changes that you can see with your own eyes. Okay, that is how cell death is going to happen. So look at this. Because cell death, we've said it can either be necrosis or apoptosis. These are the differences that you can see here. When there's a stressor that has been produced, and in necrosis, there's going to be swelling of the endoplasmic reticulum, the ER, and the mitochondria is also going to swell. The membrane is going to bleb. You can see these things that are coming out. These are blebs. Okay. And then if the injury progresses, what you are going to see is they're going to be breakdown of plasma membrane. The plasma membrane breaks down, the organelles and the nuclear contents are now going to leak out. This is what differentiates necrosis from apoptosis, because in apoptosis, there is nothing like the cell membrane breaking. Okay. And so when the contents that were in the membrane leaves, can you see that in necrosis you also have these things we are calling as myelin figures and amorphous densities in mitochondria? We're going to be seeing things in mitochondria. While for apoptosis, when there is a stress that is given to the cell, there's going to be condensation of the chromatin, and then the membrane also bleb. But what will happen is that those blebs are going to start breaking off from the cell. There'll be no break in the cell membrane. And so there's going to be fragmentation of the cell. And we call that those things that we are forming as apoptotic bodies. These apoptotic bodies now are going to be phagocytosed by the macrophages. And that's how apoptosis happens. So necrosis is a type of cell death in which there is enzymatic digestion in lethally injured cells. Cells that have died to cells that have been injured to a point of death, they are now going to be digested. There's going to be loss of membrane integrity, denaturation of intracellular proteins, and there's going to be leakage of the contents, as we said earlier on. So look at this. Because the things that belong to the inside of the cell are leaving the cell, that is going to lead to a response, because anything that is found inside our cells, immediately it leaves the cells, the white blood cells are going to notice that this guy doesn't belong here. What the white blood cells are going to do is that they're going to go there and attack those things, and that leads to what we call inflammation. Inflammation will be the next topic we're going to discuss. So just know there's going to be inflammation. Inflammation is characterized by the place where inflammation has happened being red, and then there's going to be pain. There is going to also be loss of function. So I've got features of inflammation, 5 features. We'll discuss that. So what you are going to see is that the white blood cell count will be higher than normal. Why white blood cell count is higher than normal is in necrosis? Because inflammation is because of white blood cells. We actually have acute inflammation and chronic inflammation. In acute inflammation, we're going to see neutrophils. In chronic inflammation, we're going to see macrophages. So these are the cells that will be increased. Okay. And then what happens is that those contents that have left the cell, right? When they leave the cell, they're going to be digested. So the lysosomes at the same time can start digesting their own contents, their own organelles, because lysosomes are also organelles. So lysosomes can start digesting things from their own cell. That is also known as autolysis. At the same time, lysosomes from another cell can digest uh, organelles from another cell. That's known as heterolysis. So necrosis is actually the major pathway by which cell death happens in many injuries. For example, ischemia, if there's no blood going to a tissue, exposure to toxins, various infections, and trauma. Every time necrosis happens, it is always pathologic. It's different from apoptosis. Apoptosis can be pathologic or physiologic. It can be okay. For example, when red blood cells reach 120 days, they are going to die. That is physiologic. But necrosis is always pathology. Is always there is a problem. So necrosis can result in cessation or loss of function of the involved tissue and the release of cellular enzymes that can be detected in blood. For example, if someone has got myocardial infarction, you are going to see the cells of the heart have died. So there are going to be these enzymes being released from the heart, and those are known as cardiac enzymes. So if you be able to see these cardiac enzymes in blood, you'll be able to tell that okay, this person has got heart attack or myocardial infarction, because you can only see these when the cells of the heart have been broken down. You have got 6 different types of necrosis: coagulative necrosis, liquefactive necrosis, gangrenous necrosis, caseous, fatty, and fibrinoid. Coagulative necrosis, this is characterized when there is blood flow to an organ being affected. Remember, we said that if blood is not going to an organ, what happens that that organ is going to undergo death. Why death? Is because of ischemia. There's no blood supply to that organ. Okay, so in coagulative necrosis, this is actually the most common type, and it is seen in every organ in the body except in the brain. So if there is blood going to an organ, it is going to undergo coagulative necrosis, except the brain. Please take note of that. For example, if the heart is not receiving blood, there's going to be myocardial infarction. If it's the kidney, there's going to be renal cortical necrosis or infarction. If it's the spleen, the liver, there's going to be an infarct. So that is what happens. You can see this organ, it is looking pale, right? It is like at this point, you can see it's pale. It's because there's no blood going there. That's the kidney. There's no blood going there. That's why it's pale. And then the morphology that you are going to be able to see for something that has undergone coagulative necrosis is that it's going to be pale. Please, you need to know the gross and the histology. So for the gross aspect of coagulative necrosis, the region is going to be pale. Okay, the affected organ is going to look pale and firm because no enzymatic lysis occurs as the enzymes. So there's no really lysis happening, just blood hasn't gone there, so there's no destruction of the seal of the tissue. Please take note that the architecture of the dead tissue is preserved. This is how the normal kidney is supposed to look like. So even when there's no blood going there, the organ still looks the same, but then it is pale because blood is not going there. So architecture is maintained. And then microscopically, what you are going to be able to see is preservation of the general tissue architecture, as we said, but the nucleus is lost. There is actually what is known as a ghost outline. You can see there is a dead part here, which is pale, and then you have got a normal area that is around. That is the histologic appearance. The nucleus disappears, and everything else is going to look red. You can see there's no nucleus. And then the next type of necrosis is the liquefactive necrosis. This is the same as coagulative necrosis, but it happens in the brain actually, because we said that for the others other organs undergo coagulative necrosis, but the brain, no, it undergoes liquefactive. Liquefactive, this is where the organ transforms and start looking like a liquid viscous mass. Okay, like a liquid, it will look creamy yellow because of the presence of dead red blood cells that are going there. Remember, white blood cells, not red blood cells, but white blood cells are the ones going there. That's why the tissue appears creamy yellow. Remember that white blood cells are also known as pus cells. Yes. Okay. And this condition is normally seen in bacterial and fungal infections because microbes will be able to stimulate the accumulation of inflammatory cells. And they say that the cells of inflammation are white blood cells like neutrophils in acute and macrophages in chronic inflammation. And these are the cells that will start to digest the tissue, and the tissue looks now liquid. So these are actually characteristically seen in tissues that have undergone hypoxemic cell death. There's no blood going there, and it's also going to be seen in bacterial infections. Okay. The affected tissue is softened or liquefied by the action of hydrolytic enzymes, which are either released from the lysosome in the brain cells or released from the neutrophils in the pus or abscess. So in the brain, lysosomes can be released, they start chewing up the brain. That causes this liquefactive necrosis. And then for pus or an abscess, you know how an abscess looks like, isn't it? Or a pus. Like, if you bend yourself and then you press on where you've bent yourself, there's liquid flowing out that is looking pussy like that. It's because of the white blood cells, which are there, the neutrophils being released. This is how the brain looks like if it undergoes liquefactive necrosis. You can see it is it is looking like a liquid here. It has been chewed, looking liquid like. So the creamy yellow appearance. And then microscopically, you can see there's also going to be the ghost outline. The center is necrotic, the center is dead. You can see the center here, and then the surrounding, you have got the surrounding cells. All these dots that you can see, these are neutrophils, and then the other area now is normal. So that's the ghost appearance, and that's how an abscess is formed. So I've got the center containing necrotic cells, the dead cells, and the neutrophils, and that is known as a pus or an abscess. Caseous necrosis is derived from flammable white appearance of the area of necrosis. That's why I call it caseous. It looks like a cheese-like appearance, caseous. So here the necrotic area is going to appear as a collection of fragmented or lysed cells and amorphous granular debris enclosed within a distinctive inflammatory disorder. So please, what is important in caseous necrosis is that the appearance is characteristic of a focus of inflammation. So there's a formation of a granuloma. What is a granuloma? And actually, caseous necrosis will typically occur in TB, patients that have got tuberculosis. TB is caused by Mycobacterium tuberculosis. You discuss it in microbiology. This is how it appears. Can you see this looks like a cheesy appearance? So the gross appearance for someone that has got caseous necrosis is white, soft, cuddy, cheesy looking caseous material like this one. And then microscopically, we've talked about a granuloma. What is a granuloma? A granuloma is formed when you have got look at this, there is actually inflammation, and then you are going to have the middle area where you have got dead cells. We call that as the central caseous necrotic area, and then the surrounding area has got the inflammatory cells, the macrophages. Some of the macrophages are joining together, they end up having one big cell that has got a lot of nuclei, and we call that as a giant cell. Okay, so this is what forms a granuloma. They can actually even ask you. And then you are also having these cells which are known as epithelioid macrophages. These are basically modified macrophages. So this is what forms a granuloma. Fatty necrosis, just like any type of necrosis, here blood is not going to the adipocytes. Okay, blood is not going to those adipocytes. So if that doesn't happen, since blood is not going to these adipocytes, they are going to be able to die, and chemical molecules are released that start the process of trying to get rid of the dead cells. And that process includes, for example, enzymes that break down the fat into smaller molecules that can be absorbed by the bloodstream. Calcium deposits, which is found in the fat necrosis, is very essential for the action of the enzymes that will be able to break down these fatty areas, or the fat. So the cell membrane are thickened and eosinophilic. They look pink with no nuclei. Sin Fat necrosis will cause karyolysis, the disappearance of the nucleus. Okay, karyolysis lump. Fat necrosis can also be seen in the breast fat, abdomen. So basically, regions where you have got fat, that's where you expect to find the fat necrosis, and it normally requires no treatment because it normally resolves on its own. For example, you can see the gross appearance. Can you see here that you have got, for example, in acute pancreatitis, the pancreatic cells uh, release the lipase enzyme into the fat in the abdominal cavity, and that will cause the pancreatic cells to start digesting the fat. They release the pancreatic lipases are going to break down these cells into glycerol and fatty acids. That is what makes up lipids, isn't it? And then the fatty acids will now combine with calcium. That combination of the fatty acid and calcium is what will form a calcium soap, which looks like a chalky white spot. These are the spots that we can see. Okay, the chalky white spots there. And that process is known as saponification. So this is what we can see on a gross appearance. We can see these chalky white spots. And then microscopically, you can see nearly all the cells are replaced. Okay. The foci of the fat necrosis contains shadowy outline of necrotic fat cells with basophilic calcium depots surrounded by an inflammatory reaction. This is the normal cell. You can see normal adipocytes. You have got these white things, those are adipocytes. And then in fatty necrosis, you can see you have got some other areas where I've got calcium deposits. And those are the ones that you are going to be seeing with different colors. Fibroid necrosis, where does it happen? This one specifically happens in the blood vessels, like in the wall of the arteries, the arterioles, and the capillaries. It happens when there's a deposition of fibrin in the arterial wall, which appears smudgy and acidophilic or eosinophilic. So why does it happen? There's actually an autoimmune disease. Auto, remember, is destroying yourself, right? So the body produces antibodies against their own antigens, and these antibody antigen complexes, they are now going to be deposited into the arteries. Okay, they'll be deposited into the arteries, and as that is happening, there is fibrin which is coming out of the cell. So this is the morphology that you are going to be able to see. You have got the whole of the artery being pinky with dark neutrophils. Those dots that you can see, those are neutrophils. That's because of the fibrin that has been deposited in the wall of the arteries. Gangrenous necrosis is not supposed to be actually something we should discuss here, but it's a common term that they use in clinical practice. This term normally applies to the limbs, like the lower limb, when there's no blood when blood supply is lost. Okay, so you can see like this region that has been injured. So what happens when blood supply is lost to an area? The area can start being eaten up, really, like the limb will just be eaten up. Why does it happen? And you have got different types of gangrenous necrosis. It can be dry or wet. I want you to just take a bit of time to read that. But what happens that you don't have blood going to an area? Let's say, for example, someone has got diabetes. When someone has diabetes, what happens is that they are going to have accumulation of lipids, and those lipids will be able to block blood supply to an area, and so it ends up dying. That's from the gangrene. Okay, so that is that. And how does necrosis really happen? There's going to be damage to the mitochondria. When damage happens to the mitochondria is important in the production of ATP. So there's a reduction in ATP, and that is what leads to a lot of effects. Besides that, when the mitochondria is damaged, there's going to be leakage of what is known as pro-apoptotic proteins, but this will be apoptosis. This is going to be happening in apoptosis. Again, when there is damage to the mitochondria, calcium can be able to flow in, okay, and that will lead to increased mitochondrial permeability, the activation of a lot of enzymes when calcium gets to enter. Reactive oxygen species also increase in necrosis, and those can damage lipids, proteins, and DNA. The membrane can as well be damaged. The plasma membrane, if it's damaged, there's going to be loss of contents of the cell. If it is the lysosomal membrane that is damaged, it means that for the lysosome, they will start releasing the enzymes that they have, and those are going to start now digesting other organelles. Proteins, if they are misfolded, they'll be able to damage, okay, protein misfolding, and also the damage to DNA. This can activate what we call pro-apoptotic proteins. Now, this will be apoptosis. So, I've already discussed this. You can see the reduction in ATP. It will cause calcium to start entering the mitochondria, and then potassium to start leaving the mitochondria. Sodium and water start also entering into the mitochondria, and that will lead to the endoplasmic reticulum to swell. And then there's also going to be the cell being able to, the cell losing the microvilli, and then the cell will be forming blebs. Actually, reduction in ATP will cause water, sodium, and calcium to enter the cell, not just the mitochondria, the entire cell. That's why the cell is swelling. The endoplasmic reticulum is also swelling. Okay. Reduction in ATP as well will cause diversion from aerobic respiration to anaerobic respiration. And so what happens is that you are going to be breaking down glycogen. You are going to be producing a lot of lactic acid. Lactic acid produces acidosis, and that causes the clamping of nuclear chromatin. Besides that, when there's a reduction in ATP, there's going to be detachment of the ribosomes, and so there's a reduction in lipid protein synthesis. So the lipids end up depositing themselves in the different body parts. When there's a calcium flux, calcium entering the cell, what does that cause? So calcium flux can lead to cell death again. Okay, increase the cytoplasmic calcium, reactive oxygen species, or lipid peroxidation leads to mitochondrial injury. When calcium enters the cell very much, it leads to injury, and so there's a reduction in the production of ATP. When that happens, what happens is that hydrogens start leaving the cell, and when hydrogens are leaving the cell because of increased mitochondrial permeability, there's going to be a loss of potential of the mitochondria. There is inability to make ATP that causes necrosis. At the same time, if there is injury to the mitochondrial membrane, what happens is that content from the mitochondria will leave like cytochrome C. Cytochrome C and other pro-apoptotic proteins. Pro means before. These are going to lead to apoptosis. Please take note, cytochrome C is very important for apoptosis. We already discussed the reactive oxygen species. Now, what is apoptosis and how does it happen? Apoptosis is programmed cell death. It can either be pathological or physiological, different from necrosis, which is always pathological. So this is where the cell is committing suicide. So it's also known as cell suicide. And it can happen because the cell has seen that maybe it is forming what is not right. For example, it is forming wrong proteins, so the cell can end up killing itself. The physiological conditions that lead to apoptosis is during embryogenesis, as I explained earlier, when you want to form your hands like that, or also the endometrium in the menstrual cycle can undergo apoptosis. Also, the regression of lactating breasts, because if you stop breastfeeding, you should stop producing milk, right? And also prostate atrophy after castration. So if you cut a certain part of the prostate, the entire prostate should atrophy. This is how you treat prostatic uh, benign prostatic hypertrophy. And then pathological conditions that can lead to apoptosis can be maybe radiations, viral infections, and such. So how does apoptosis happen? Please, this is high yield, right? This is high yield, high yield. How does apoptosis happen? So we have got what we call the death pathway genes. Those are genes that cause the death to happen. So these death pathway genes are going to be activated. When they're activated, they are going to cause the cell to shrink. Please, the cell doesn't swell like in necrosis, it just shrinks. And when a cell is deprived of growth factors, or the cell's DNA and proteins are damaged beyond repair, the cell is going to kill itself. And what will happen is that there's going to be nuclear dissolution without a complete loss of membrane integrity. This is the difference with necrosis, because in necrosis, there's the loss of membrane integrity. That is why there was the leaking of contents in the cytoplasm. So what happens is that the nuclear is going to condense, the DNA is also going to fragment, and this is the characteristic feature of apoptosis. The cell fragment is also going to form beads, which we call apoptotic bodies. And these apoptotic bodies, but what happens is that the plasma membrane will remain intact, though you are forming these apoptotic bodies. These are now going to be phagocytosed by the phagocytic cells, and that is how apoptosis happens. So another important thing you need to know is that as this is happening, inflammation doesn't happen in apoptosis as it was happening in necrosis. Why? Because we are not releasing contents are found in the cell. So what are the important enzymes that play a role in apoptosis? You have got caspases. These are cysteine proteins. These are very important caspases. You have also calcium and magnesium dependent endonuclease. And how do you regulate apoptosis? You have got anti-apoptotic proteins. Anti-apoptotic proteins, these are proteins that stop apoptosis. For example, BCAO2. And then you have got pro-apoptotic proteins. These are proteins that promote apoptosis. These, for example, BAX gene. You are going to have BAX and BAC. So for apoptosis to happen, it has got two pathways. Intrinsic pathway, which starts from the mitochondria itself, and the extrinsic pathway, which is mediated by what we call the death receptors. So the intrinsic pathway of apoptosis, how does it happen? The first thing is this: there is a stress to the cell. If there's a stress to the cell, that is going to, let's say for example, there's damage to the DNA, maybe oxidative stress, maybe there's no growth factor, the absence of growth factor, because if you're not telling the cell to grow, well, the cell is going to interpret it that kill me, right? So all these signals we've mentioned here are going to activate the tumor suppressor protein P53. And this P53, the next thing that it will do is now to activate pro-apoptotic proteins. Remember, these are proteins that promote apoptosis. You have got what we call the BCAO2 family. The BCAO2 family contains both pro-apoptotic proteins and anti-apoptotic proteins. The pro-apoptotic proteins which promote apoptosis is BAX and BAC. Please take note of these two. So what will happen is that P53 is going to activate backs and back, which promotes apoptosis. Okay, remember this P53 is what? It's a tumor suppressor protein. So the backs and back are going to go to the mitochondria outer membrane. While in the outer membrane of the mitochondria, there's going to be mitochondrial outer membrane permeabilization. They are going to make it permeable. How do they do that? They're going to start forming pores in the mitochondrial membrane. How? Normally, what happens is that you have other BCL2 family proteins like BCL2 and BCLX. These are anti-apoptotic. These guys stop the function of backs and back. But because of these stressors to the cell, backs and back have ended up being too many than BCL2 and BCLX. So because BCL2 and BCLX have been outnumbered, the backs and back will now form pores in the mitochondrial membrane. The next thing that happens, because the pores have been formed in the mitochondrial membrane, there's going to be release of cytochrome C from from the outer mitochondrial membrane into the cytoplasm. All right. Actually, the there's going to be release of this cytochrome C from the intermembranous space where it stays into the cytoplasm. And when the cytochrome C goes into the mitochondrial membrane, I mean into the cytosol, it will bind to what is known as apoptotic protease activating factor 1. You can simply say APAF1. When cytochrome C and APAF1 binds, they need ATP. And when this happens, there's going to be a conformation change that happens in APAF1, and it will allow it to oligomerize and form a complex which is known as an apoptosome. So apoptosome is going to be made up of what? Cytochrome C, APAF1, and what is known as the procaspase 9. So procaspase is before a caspase, right? Procaspase 9 is the first caspase that is recruited in the intrinsic or mitochondrial pathway. Please take note. This is known as the initiator caspase. It's the one that will be activated first, and then it activates other caspases. All right, take note. That's very important. Procaspase 9. So the apoptosome has now recruited procaspase 9, which is the initiator caspase. It will break this procaspase 9 into caspase 9. It was pro, but now it's now caspase 9. Once caspase 9 is activated, it will now activate other caspases. For example, caspase 3, caspase 6, caspase 7. These ones are known as executor caspases because they are the ones that carry out apoptosis. So when these executor caspases are activated, then what will happen is that these are now going to degrade various cellular components, leading to characteristic morphology that happens in apoptosis. For example, there's going to be cell shrinkage, chromatin condensation, DNA fragmentation, membrane bleeding, and the formation of apoptotic bodies that we saw. These apoptotic bodies are now going to be engulfed by macrophages. And this is the intrinsic pathway of apoptosis. They can bring you a question right about the intrinsic pathway of apoptosis, 20 marks. Okay, so this is the intrinsic pathway. The extrinsic pathway is also known as the death receptor pathway. Here, what happens is that the signals you have got external signals, not really death, not really failure of growth signals, but external signals coming in. Like specifically, you have got what we call the death ligands. So death ligands are going to bind to death receptors. What are the death ligands we have? We have got Faz ligand and the tumor necrosis factor alpha, TNF alpha. These are going to bind to their receptors, Faz receptor and TNF receptor on the cell surface. Once these bind, they are going to form what is called death-inducing signaling complex, DISC. Death-inducing signaling complex. So the binding of the death ligand to the death receptor is going to lead to the recruitment of adapter proteins. The adapter protein that is going to be recruited when the death ligand binds to the death receptor is FADD, Faz associated death domain. Beside this, so I've got three, please take note of this. Death receptor plus death ligand is going to recruit FADD and procaspase 8, and that is what forms the disc. So can you see the difference that in the intrinsic pathway, the initiator caspase was procaspase or caspase 9. In the extrinsic pathway, the initiator caspase is caspase 8. So once you form this disc, the death-inducing signaling complex, you take note of what it's made of. I've put them in blue here. So procaspase 8 is now going to be activated into caspase 8. And that caspase 8 is the initiator caspase that to activate other caspases like 3, 6, and 7. Okay. And these are the ones that now will carry out the execution of apoptosis, just like we talked about in the intrinsic pathway. But besides that, caspase 8 can also break down the BH3 only protein, which is known as BEAD, into its truncated form, which is known as T-bead, that is truncated bead. And then what this T-bead does is that it's going to translocate, it will go to the mitochondria, and then it will promote the mitochondria to become permeable. When it becomes permeable, it will release cytochrome C. Cytochrome C again, it will do the same thing it was doing in the intrinsic pathway. So in other words, the extrinsic pathway can also bring in the intrinsic pathway, so that altogether they can be a very stronger signal for apoptosis to happen. Okay, so this is the general that happens in the extrinsic. TNF alpha binds to the receptor. There is the recruitment of the TAD, TRAD, the FADD actually, and you also have the bringing in of procaspase 8 that forms what we call the FADD. Actually, the disk, the death domain, and then that is going to activate the caspase 8. Caspase 8 is going to activate caspase 3, not only caspase 3, also 3, 6, 7, and all other caspases, which we call executional caspases. And then these are going to cause the apoptosis to happen. What are the changes that happen in apoptosis? So on histology, apoptosis is going to involve single cell or a cluster of cells. A lot of cells can undergo death, and then the cells will be intensely eosinophilic, but there is no inflammation. This is what you need to take note of. There is no inflammation. So these are the differences between apoptosis and necrosis. Your test one can come like this: write a diagram. Using a diagram, talk about the differences between apoptosis and necrosis, 20 marks. So when you look at the cell size, in necrosis, the cell is normally large because there is swelling, while in apoptosis, the cell is small because there is shrinkage. If you look at the nucleus, we said that for necrosis, there's going to be pycnosis, karyorrhexis, and karyolysis in that order. While for apoptosis, there's going to be fragmentation into nucleosome size fragments for the same nucleus. So these stages don't even happen. And then for the plasma membrane, in necrosis, it is disrupted. We said that it is going to break, while in apoptosis, it is intact. And then the cell contents in necrosis, there's going to be digestion by the enzymes. Okay, the cell contents can also leak out to the cell, while in apoptosis, the cell contents are intact. They can only be released in apoptotic bodies. And then adjacent inflammation, we said that necrosis, there's going to be inflammation of the adjacent tissue, right? There's going to be inflammation. But in apoptosis, there's no inflammation. And then physiological, pathological, we say that necrosis can either be physiological or pathological. Apoptosis is always, sorry, we said that necrosis is always pathological. Apoptosis can anyway be both physiological or pathological. So that, my friends, is what we call cell injury.